And we were looking at this delightful but also mysterious phenomenon that we had 25 years of virtually unbroken increases in death. And we were trying all kinds of things that seemed sensible, and deaths keep going up. And then in the middle of 2023, you see this sudden reversal of deaths dropping. Why would that be? Well, it couldn't be something we were doing all the way along. I mean, as important as treatment is, as important as...
Hi, and welcome to Season 3 of Neural Compass. I'm Mark Jacobstein, President and co-founder of Jiminy Health. I am really excited today to be here with Dr. Keith Humphreys, PhD, who is a professor at Stanford, one of the world's experts on addiction, an OBE, which we'll have to talk about at some point, how you became a member of the British Empire, I'm quite curious about, and advisor to at least 3 US presidents, perhaps more. One of the funniest things, actually, Keith, I should admit, when I was researching you that came up with Claude is that you are apparently a remarkably sharp dresser by Stanford professor standards. I'm always curious what the AI would say about me. I suppose I have to ask. In any case, I'm really happy to have you here today.
Well, very glad to be on the show. Thanks for having me, Mark.
Maybe we'll start with, most of your work has been centered around addiction and treatment of addiction throughout your career. And if you don't mind, give me a little bit of the backstory on why this was something that interested you and sort of how you got here.
Well, to be honest, I got in by a happenstance, really. At least that's how I started. I was a college student. I knew I was majoring in psychology. I knew I wanted to do something in mental health. I had no idea what. And I was flipping burgers at a Wendy's on Trowbridge Road in East Lansing, Michigan, to pay my rent. And, it's not a pleasant job. Speaking of dressing, you do not wear attractive clothes. I was in one of those ridiculous outfits with a funny hat. And a friend of mine came in looking fantastic in office clothes and relaxed, and said she was graduating and was leaving a job as a research assistant in the medical school. And she said, if you want, I can recommend you for the job. And I said, oh, well, I was making $3.35 an hour, which was the minimum wage. And I asked her, what does this job pay? And she said, $4.40 an hour. And it's a project on addiction. And I said, wow, I'm really interested in that, which I had never even thought about being interested in. I was interested in the fact that that was $1.05 more an hour. And, I can do the math. That sounds like a great job. And so the coincidental thing is that if she had said it's depression, schizophrenia, family therapy, I would have said, yeah, no matter what. So that was luck that got me into it. But then, of course, I might not have liked it. So why did I like it? And there are a couple things. One is the human part of it is very compelling. So in this job, I was interviewing people as they were entering the addiction treatment system. And, it is, you see everything that is interesting about life and the experience people are addicted. You see struggles with control, search for meaning, love, death sometimes, conflict, recovery, redemption, all that. And so I found that all very, at a human level, pretty fascinating. And then there was the intellectual puzzle, which is also interesting. Why do people do this? Why does Homo sapiens, for example, prioritize snorting a powder over eating food when they haven't eaten in 3 days? Why is it that we are capable of getting into a disordered state where you think everything evolution would have told us, in terms of take care of relationships, get warm when you're cold, eat when you're hungry, all that could be thrown aside for the sake of, molecules that have no nutritive value at all. And that is the fascinating thing about addiction. So there's two things together. It had the heart and it had the head. And that is what's kept me doing this for, oh my gosh, 40 years.
It's an amazing origin stories. And I have to tell you, it's probably the first time I've heard somebody talk about just sort of truly like the role of luck in finding what turned out to be your life's work, which is wonderful. And obviously you've had an incredible impact. Let's zoom in on some of the things with addiction that have been really important. One of the things that you wrote some important articles about over the last few years, I think in 2024, put out some information on the decline in overdose deaths. Starting in 2024, overdose deaths were down 27%, the largest single year decline ever recorded. I think most Americans have no idea that this happened. And you, I think, helped to put together some of the studies on so why did this happen? If you walk us through why you think it did, and maybe how you feel about the future and sort of where we're headed.
Yeah, so that paper was led by Casey Vangelov of the University of Maryland. It was a team of researchers, which I was one, and published in Science this January. And we were looking at this delightful but also mysterious phenomenon that we had 25 years of virtually unbroken increases in death. And we were trying all kinds of things that seemed sensible, and deaths keep going up. And then in the middle of 2023, you see this sudden reversal, both in the United States and in Canada, of deaths dropping, and they've continued to drop, by the way, to the most latest data we have to the end of 2025. So like 45% below. Why would that be? Well, it couldn't be something we were doing all the way along. I mean, as important as treatment is, as important as overdose rescue medications like naloxone is, we were doing that all the time. So what happened in 2023? And that's what we were trying to figure out. And, what we did was we looked at, drugs that had been seized by law enforcement, particularly fentanyl, which is the synthetic opioid, which is by far accounting for most of our overdoses in the United States, and saw that the purity and availability of that drug was dropping dramatically. So law enforcement was making fewer and fewer seizures. And when they seized it, both in powder and pill form, the strength of that drug was declining really rapidly. Parallel to that, we looked at Reddit groups, where there's groups where people talk about their drug use and finding drugs. And there was this huge surge in people using words like drought, weaker, withdrawal, I can't find drugs. I'm quitting drugs because it's, they're
So
too hard to get
this
now.
was literally the drugs were simply not as strong, and as a result, not as deadly.
Not as strong and not as available. So, so that suggests a supply shock. Something must have happened to the drug supply. Then the question would be, well, where did that come from? And to look at that, we looked at the United States and Canada. Those are the two, other than Estonia, a small European country. There's only two countries, U.S. and Canada, have really serious real serious fentanyl problems. And we looked at the timing of the sort of drops in overdose and drops in other indicators of the problem, and show that happened around the same time in the two continents. And why does that matter? Because the way the fentanyl trade works is precursor chemicals, which are sort of like the drugs you use to make the drugs, start in China, and they go to Canada directly, and then Canadian traffickers convert those to fentanyl. Whereas the U.S. route is a triangle. The precursors go to Mexico, Mexican cartels turn the fentanyl and ship them north. So if this supply disruption had been due to, say, a Mexican intervention, you would have seen a drop in the U.S., but not in Canada, because Mexico has nothing to do with the Canadian drug trade. But since it was in both places at both times, the most plausible explanation, and it's just plausible, it's not like we have direct data on Chinese government action, but the most plausible explanation is China put pressure on those producers, and that was felt in downstream drug markets across all of North America.
There's so many interesting things to unpack there, including actually, and this may be a field from your area of study, but I'm curious as to why fentanyl isn't a problem anywhere in the world but Canada, the United States, and Estonia, of all places. Like, why is it a problem in Estonia, and why isn't it a problem in, say, in the rest of Europe, for example?
Well, this is one of the effects of prohibition. If Amazon could sell fentanyl, it would be available everywhere on earth at a touch of a button. But, one of the functions of prohibiting certain markets and prohibiting the production of certain products is diffusion of those products becomes dramatically less efficient. So Estonia, for whatever reason, developed a fentanyl market, had it for 20 years. You can ride a ferry from Estonia over to Finland, in like 25 minutes, and yet it's never crossed. And you see that a lot in illegal markets. In a legal market, it would be advertised all over, it would be distributed publicly, and it would have spread everywhere because from a seller's viewpoint, fentanyl costs about 1% what fentanyl or heroin does to produce, because there's no plants involved. There's no agriculture, there's no farms, there's no shipping. It's all whipped up in a lab. So you would think that would create a huge incentive on the supply side to make more fentanyl. But it hasn't spread because it's illegal. And that is something we get in the much blind, people complain about prohibition. So one thing they forget is prohibition really limits the spread of illicit drugs.
So actually, I'd love to use that as a segue into something I think has been very important in your career, sort of discussion of the role of policy and law in the treatment of addiction. And this is something people have talked about for a long time, lots of experiments have been done famously in Portugal, et cetera. And I think the results, as I understand it, have been much more mixed and nuanced than sort of people were hoping. And I'd love it if you could sort of talk us through some of the things that your work helped to uncover as far as sort of the nature of public policy and the role of kind of community and law and its effect on addiction.
Let's start with some terms. So legalization typically refers to the legalization of the production and sale and advertising of illicit drugs. That's a separate problem from decriminalization, which generally means reducing penalties on the users, the person who just has a little drugs because they are going to use them themselves. And we do, if you look at legalization facts, you can see the tobacco industry is an example of legalization policy. I mean, when you have a legal industry, in a modern capitalist world with the global commerce, those drugs will always be far more available than any other drug. Tobacco kills more drugs by a factor of 10 than every single illicit drug put together. But there are costs always.
And alcohol would probably be on that
Alcohol
list.
kills
That would
several
probably
million
be number
people.
2.
Yes, it is. But there are obviously costs of prohibition. I mean, anything you prohibit, no matter what it is, there's enforcement costs. There can be injustice, all those sorts of things, and that's important to weigh all those in account. Decriminalization is less radical because you're still saying it's not legal to manufacture, sell, and so on, and you're reducing the penalty on users. And sometimes, I think, for example, if you go back, in the 50s, where people were put in prison for a decade, literally, for using marijuana, you say, wow, that's a lot worse harm from the punishment than from the drug could ever do. And so that's one reason people think about, decrim is, can make those a more sensible trade-offs. For example, California in 2010 converted possession of cannabis from a misdemeanor to a ticket, essentially like a parking ticket. So what Oregon did was, more radical in that they said for all drugs of any sort, possession was completely legalized. They also, in small amounts, and they also defelonized large possession. So if you had a truckload of cocaine, it was only a misdemeanor. So that was a decision that probably, accelerated the drug trade because what a deal if you're a drug dealer. They claimed they were doing what Portugal does, but they really weren't, because the way Portugal works, and I've spent a lot of time in Portugal. I know the people designed their policy. They decriminalized, but they did not legitimize or stop discouraging drug use. So if you are using drugs on the street in Portugal, police officers can pick you up and take you to what's called a dissuasion commission, which does pretty much what it sounds like, who can pressure you into treatment. Like they can say, well, we've done an assessment. We think you need treatment. You're a taxi driver. We're taking away your license unless you go to treatment. So they have that in. All of that was taken out by the Oregon advocates. They wanted no pressure whatsoever. The other thing that's different is Portugal is a conservative society by far compared to the U.S. in general, and certainly compared to the West Coast. Portugal was a dictatorship in living memory. It is a Catholic-inflected communitarian society with very strong families. Many people, like if you go to Lisbon, you will meet people who not only do they live there, but their mom and dad live there, and their brothers and sisters live there, and their parents live there. So there's a lot of watching and social constraint. And when you have a lot of social constraint, and social constraint is something we all encounter far more often than we encounter the law, you have a certain amount of sort of protection, around drug use getting out of control. Whereas in the West Coast of the United States, here we are, we're individualistic, we're capitalistic, we're do what you want to be. You don't owe anybody anything.
Most people who are here are not from here. I mean, some of the things that are very interesting here are some of the double-edged swords of the mobility, for example, of the United States, which has led to extraordinary opportunity and economic mobility, and people being able to get out from under, say, stifling situations or a family situation that's no good. It also means that people live a long way from where they were born and away from some of the positive effects of social constraints that are a function of being in a neighborhood where everybody knows you.
Yeah, very, very well said. And exactly the case. I mean, I've lived out here, for over 30 years. I love it out here. The freedom, the individualism. Stanford, I think, has that culture, and it's a very nice culture. So you can be creative. It's why, the music scene, the art scene, the Silicon Valley, all our entrepreneurs. Why, lesbian and gay rights, and there's a lot of people go to the Castro who grew up in small towns who could not be who they were there, and then they came here and they could. So there's plenty of good things about it, but that same kind of thinking and culture is a lot, goes from being a good thing to a bad thing when we're talking about fentanyl use, which kills a lot of people and is not really you expressing yourself. It's you being, losing your self-control to a drug, and that was forgotten by the folks in Oregon. So, there's forgot that, if you take away, you already didn't have the cultural constraints, and now you're moving the legal constraints. There were basically none. And so, Oregon had the fastest growth of overdose of any state in the country. As property crime was dropping and violent crime was dropping in the United States, it was going up there. And the other thing that's hard to capture with statistics, but I will just tell you, I went to Oregon. I go to Oregon a lot for some collaborations up there. Just the quality of life. If you're just in a neighborhood in Portland, say, and you just wanted, kids came home from school and you just wanted to go to the park with them, and you can't. The park is an open air drug scene, and by the way, you're going to have to step around a bunch of tents on your sidewalk, and there's someone using drugs at your kid's school and all that sort of thing. Those things aren't necessarily would show up in crime statistics or overdose statistics, but it does change what it is like to, for example, try to raise a family.
Yeah, sand in the gears of the quality of life. It's interesting because there's been there was a minor league version of this in San Francisco as well, where folks whose politics were probably generally quite liberal started to experience the impact of, in some ways, the first and most important role of the state is to keep you safe. And if you and your children safe, and if you don't feel that, then you're going to see policy changes. I'm curious, and perhaps there's no way to sort of tease these out as to whether or not you feel like the role of the social connection, some of the things you described about Portugal as a historically conservative state where people largely live in neighborhoods where they grew up, a lot of implicit social pressure was more important, or this sort of dissuasion and almost coercion to, say, get into treatment. And probably difficult to tease that out statistically, but perhaps, I don't know if you have a sense.
Yeah, I think the social controls are way more important. I mean, and I feel that way about everything. I mean, if you look at something like drunk driving, which is used to be considered a source of humor. If you look back, there's if you watch TV shows and things like that, and sort of winked at, and now you're a pariah if you leave a party drunk and say, one more for the road. Well, that is something more people will encounter. The look on their friends' faces, the disapproval of their families, then will be arrested for drunk driving. We don't interact with the law that much. When you add up all the arrests, the proportion of crimes compared to arrests, the rest are trivial share of that. But whereas, how often do we have to think about what does my family think? What do my neighbors think? What does my boss think? All the time. And so those will explain a lot more about substance use, social norms, cultural norms, your day-to-day things than the law. The law is kind of like maybe the backup, but mostly, the reason you do the things you do is going to be the people you spend the most time with.
Yeah, it's interesting you say. I will say, I've said this before on this podcast. I think the most important heuristic for almost all human behavior in almost all situations is what are other humans doing, and there's a good evolutionary reason for that. If people aren't eating the thing, it's probably poisonous. If people are dressed a certain way, it's probably appropriate for the weather or the social situation or for some reason. And so the simplest, least cognitively challenging thing to do is to behave like people around me. And I think we've all experienced that.
But yeah, I mean, we are a mimetic species, and the other part to it too is, of course, that's about resource gathering and sharing. So since we used to have a time of more scarcity of things like food, cooperation was essential, and you couldn't damage your social ties that much. You would literally die if you were cast out of the tribe, and that's no longer the case. And you see, that's one reason why you see, if you go up, like I volunteer in the Tenderloin, you see people who are away from their families and using drugs on the street. In one sense, you'd say that's a function of terrible poverty, but it's also a function of enormous wealth relative to what there was 1,000 years ago. Somebody like that would just simply not have been alive. You couldn't survive without social support and bonds through most of the history of Homo sapiens you can today.
So maybe as a segue there, some of the other work that you've done has been in around the efficacy of organizations like Alcoholics Anonymous, and it strikes me as interesting. I mean, somebody a psychologist who presumably also believes in some of the other methods of, say, treating our mind and brain, whether that's therapy or SSRIs or various drugs that we have, and ways that we treat anxiety, depression, addiction, et cetera. clearly sort of seem to interweave with kind of the social components of like how do we live. And AA has always struck me as sort of right in between, right? Like AA is it's clearly a sort of a social in group component. I don't know how much of the notion of, say, disappointing your peers or maybe seeing sobriety modeled by your peers plays into this versus just the general impact of what seems like a quasi therapeutic approach of understanding what is troubling you and getting at root causes, et cetera. So maybe I'll start with actually, if you don't mind describing some of the work you've done, and I know some of this is from earlier in your career, but around the efficacy of AA, and then maybe if we can try to pull it apart.
Yes, sure. So, as I told the story of how I got into this field in happenstance, I really had no idea what AA was when I started my career, but I started to meet some people in it, and my initial reaction, I don't mind saying, was kind of skeptical. I'd say, "Well, how could that possibly work? You have a disorder, and you got no doctors, you got no social workers, you got no psychiatrists, no medications, and somehow you're going to get better." Um, but um, but I some friends I met took me to what are called open meetings, which you're allowed to attend if you're not a member, and I got to watch it, and I was so impressed by the things you see there. Like there's social support. There's also a lot of practical strategy sharing, and there's accountability too. It's not just support. It's also hey, where were you Tuesday? There was a meeting. Or your sponsor, your senior member who's established member helping a newer member. Saying, may say things like, you say your marriage is bad and it's 100% your wife's fault, but, you contribute to this too, right? What are you doing? All that kind of stuff. And the installation of hope, if you look at the role of particularly the storytelling, when people will come up and say, here's what I was like, here's what happened, here's what I'm like now. And these kind of narratives that they have this sort of structure of, deep descent into addiction. And now I'm in AA and it's going really well. That is inspiring, and if you see somebody who looks like you, and however you define looking like you, say, oh my God, their life was every bit as much of a mess as mine is right now on this day, and they look great today. I would like that. And the people who founded it were very conscious that was the world's best sales tactic is those personal stories. And obviously it's worked for them. It's one of the,
And
among other things,
I think it's clear
fast growing organization. Yeah.
empathy works I think is easiest when you can identify with someone, and it may be as crude a characteristic as they are the same age or gender or race as I am, but I suspect that like lived experience in this particular case is actually even more important.
Oh yeah, yeah. I mean, I feel like, I don't do clinical care anymore, but I care about the people I tried to help. And I think they knew that. And I think they felt correctly that I knew something, I mean, I was scientifically trained, like, cognitive behavioral therapy and stuff. But there is some special thing that I couldn't offer them of saying, you don't have to tell me what it's like to be addicted to cocaine. I was addicted to cocaine for 10 years, and you don't tell me what it's like to get fired because I got fired too. That, you know, which is an identification, but also is very good for the shame people feel, of like, well, this person couldn't be looking down on me because they basically were me. And that can help form the, trust, in that period.
So how do you think about that in relation to maybe the sort of more formal world of treatment for addiction? So I know you do a lot of work at the VA, for example. Um, Presumably, patients who struggle, perhaps they're coming to you for therapy. Perhaps they're also on meds. Are they also typically in a program like an AA? Is that something is sort of quote prescribed? How do you think about that?
Yeah. So, I mean, in VA programs, most of them, AA or 12 steps are at least, you know, part of the mix, or at least, presented as an option. Why wouldn't they be? They're, a cheap, widely available, and often attractive, community resource. And this will be true outside the VA as well. I mean, if you go, if you walk lots of programs, you'll see, the 12 steps on the wall and all that sort of thing. But of course, it's not just that. I mean, there's still, for example, in the VA, there's all kinds of medications available. There are, job training, there are housing supports, there are psychotherapies, family therapies, all that sort of stuff that go along with that. I mean, one of the things I've always felt is it's not really my business how somebody recovers from addiction. And I've been misunderstood on that before. Like, I have two of my most cited papers. One is a systematic review done with a couple colleagues at Alcoholics Anonymous, which show all these benefits. But one of the other ones is a systematic review of acamprosate and naltrexone for which are medications for people who have alcohol use disorder. And I've had people read the AA things. Oh, you're just one of those people who hates medications. And I've had people read the medication. You're one of those people who hates puffs. I'm like, no, I don't care. My colleagues in ecology never say, well, this cancer patient got better, but unfortunately they chose radiation instead of surgery. They just want people to live. I mean, and so I think it's hurt the addiction field that it has at times had a more like a religious kind of framing of there's only one way to get to heaven. Whereas from a health viewpoint, there's many ways to get to heaven, and there's different heavens for that matter.
And probably positive interactions between the different modalities, like your social and cultural environment around you matters. A 12-step program is helpful. Formal CBT-based therapy is helpful. Perhaps, depending on what's happening in your life, you need medicine also.
Yes. And of course, the population, which is, we're talking over 50 million people, are very diverse. So, what catches one person, sort of pulls them out of the lake and they're drowning, could be utterly different than, what pulls in the other person. So it's a strength to a care system to have lots of different things. Just like, we wouldn't want like gyms if like gyms had exercise bikes and nothing else. Like that would be really strange, right? There was a time when the U.S. treatment system was kind of like that because there was barely anything. So there was, you could go to AA or otherwise no one would help you. Fortunately, now there's a lot more options, and that means from a population sense, you can help a wider range of people because it's not just a menu with one item.
Yeah, the ways in which, of course, we structure reimbursement for those are wildly different. 12-step programs are often free and volunteer driven, et cetera. So speaking actually of the way we reimburse for things, because this makes me think about incentives, et cetera. You've been a policy advisor for at least 3 U.S. presidents. I don't know, perhaps even more. What are the typical questions? What's an administration looking for when they call you?
Yeah. So the most consequential work I did was for President Obama. So I took a year off from Stanford and I worked in the White House as senior drug policy advisor. And the issue there was the Affordable Care Act, had been promised in the campaign. 60 million people voted for President Obama. So he had sort of the warrant and, he had the Congress with him. And the question is, how do you handle addiction in an overhauled healthcare system? Are we going to treat it as a health problem and take it out of the kind of mixture sort of social welfare and criminal justice where it had been? Our view was very much, and our White House office and the White House in general was, yeah, it should be covered in the same sense diabetes is covered or hypertension is covered or any chronic illness. And that is why, the ACA covers, it calls what, an essential healthcare benefit is for substance use disorder, and also that it embraces an insurance rule called parity, meaning that, you can't have a rule where you say, in your plan, an outpatient visit is $10 copay, unless it's for substance use or mental health, then it's $25. They got rid of that, and I think to the good. So that you get a lot of questions about that, like how does it fit? What does it fit in the healthcare system? And then there's a lot of questions from the criminal justice side, and that is not because someone say, oh, it's just because oppression, war on drugs. Sure, there's definitely been oppressive drug policies, but drug use, drug addiction, alcohol addiction has a lot of, what economists would call negative externalities, effects on others. So a huge amount of violence is driven by substance use. And while we would say the addiction is a health problem, if I'm addicted to methamphetamine, that's a health problem. But because of my addiction health problem, I beat somebody up.
It's also a social problem, right?
Yeah, criminal justice problem. And because there's a victim over there saying, hey, wait a minute, I want this guy to get more than counseling. He broke my nose. And so that there's that question of how do you handle that in light of the fact that, yes, it's a person, yes, they have a health problem, but also they're a threat to public safety. So I spent a lot of time on this sort of area, which is, kind of jargon is therapeutic jurisprudence. But can you hold people accountable through the legal system, but at the same time not for desire fundamentally to punish them, but a desire to change their behavior through using the leverage you get from the criminal justice system to, for example, make them enter treatment or make them submit to regular drug and alcohol tests and have consequences if they continue to use, things like that. Those are the two big bets. There's some other things we worked on, like, we mentioned the fentanyl studies. Sometimes there's issues around drug flows and foreign policy and things like that. But mostly, I'm talking to either docs or cops in my work.
Yeah, the negative externalities piece is obviously profoundly important when you're talking about substance use disorder. The other thing that is always struck me as interesting is obviously addiction is in part a disease of the brain and mind, but as we've discussed earlier, also social strictures and also impacted clearly by the law. Other people have made this point that, like, in Singapore, there is no addiction, right? Why? Because if you bring addictive drugs into Singapore, you are executed. And and the interesting thing about that is, as I pointed out, you cannot legalize away, you cannot legislate away cancer. There is no law you can implement, although you can legislate away some of the things that cause cancer. You could make smoking illegal, for example, and that would eliminate some cancers, but not all, right? Whereas they have essentially eliminated addiction and, as a result, addiction deaths with truly stringent legal strictures. Now, I'm not sure I want to live in that society, but it does point out the fact that these things are much more multifactorial, as we've been discussing.
Yeah, I mean, you have a specific agent. Like, nobody gets addicted without the drugs, but anybody can have a heart attack. Anyone can have schizophrenia, so you're right. That does bring some other policies into the frame and with thoughts about how to handle that. And that's also true in illicit markets. If you got like tobacco, we know that there are ways to constrain supply through things like licensing sellers and changing the tax structure.
I mean, simply making it illegal to smoke in restaurants, I think, was extraordinary. I was living in New York when Mayor Bloomberg was one of the first people in the world really to implement some of these anti-smoking measures. And I can't tell you how much I saved in dry cleaning, but also the impact over time in terms of the number of smokers, and as a result, the number of people whose lives have been saved I'm sure somebody's calculated, but it's truly incredible. And they were able to do that without, like, making smoking illegal, just making smoking difficult and socially less acceptable, and eventually sort of socially unacceptable. And that's been very, very powerful.
Yeah, absolutely. That's why, the rate has dropped. It's absolutely ubiquitous. In the 50s, you and I would be smoking right now, right?
Right.
During this conversation. And now it's less than 10% of Americans, which is an astounding public health achievement.
Fair enough. So if you were, I suppose you may have young researchers in your lab. I was thinking, if I was a young researcher coming into the field today, psychologist, thinking about the future of addiction treatment, how to think about substance use disorder, and reducing sort of the scourge and challenge of the disorder, where would you point them? What do you think are the most interesting areas of development in the field?
A big one is we need better therapeutics. There is no medication for stimulants, so meth, cocaine. There is no medication for cannabis. We have some meds for the other addictions, but there's always ways to get better. We have some really fascinating findings that I'm interested in on medications that were made to change the gut and, hormones in the gut, and like in GLP-1 agonists, for diabetes and obesity. And then you see people in these studies drinking, smoking, using less drugs. That's a really interesting area to try for therapeutically. There's some interesting brain stimulation work, with RTMS, that could be productive. So some stuff on therapeutics. And then the other one is, I think there's a really big deal, is trying to find a third way at the policy level between, carceral, racist, war on drugs, which we had in sort of the 80s and 90s, and a free-for-all, like they had in Oregon, the libertarian free-for-all. And, activists tend to frame this as you only have two choices. I mean, it's a classic radical thing. Like, either you're
You're with us or you're against us.
or loyal socialist, or the other way around. But the truth is, there's not just some big switch. It's a series of dials, and you have to adjust them and that sort of thing. But to figure out those sorts of things, like, like, for example, they're now figuring out in Oregon, they repealed what they did. It didn't work, but they had no desire to have a war on drugs. So what do you do instead? You got to figure out what will happen when the criminal justice system has contact with someone who's, shooting fentanyl in the park, or is running around, in a intersection full of cars high on cocaine. You have to figure that out, and then you have to figure out, like, how will you structure a treatment system that is attractive enough that people will voluntarily want to go to it, but also, when people are under pressure, from the criminal justice system or their families or their neighbors or their employers, that system is able to use that pressure constructively as a motivator for change. Those kind of things. And then the last one, things everyone forgets about, is prevention. I mean, it is the only thing I can guarantee you about addiction is if you don't use a drug, you will never get addicted to it. And after that, I'm not making any promises. I can talk about risk, but that's the only sure thing. So the extent we have succeeded in prevention, like the fact that, a huge number of young people now, are not initiating tobacco in teen years like they did, or not drinking, or not using drugs, is a much bigger impact on society than anything we do in the treatment space or the harm reduction space. Because, this will, as your listeners will know, when the brain is plastic is in most, is when we're younger. And, and that's when lifetime habits are formed, and that's where addictions are formed. So if you can get through, that period, and, from teen years into your early 20s without using some substance, your odds of ever being addicted to it for the next 60 years are vanishingly small. And so that's a huge payoff from prevention. But prevention is often forgotten, or it's misunderstood. People think, prevention is like DARE from 50 years ago, which is not the state of prevention at all. But that's something that always needs to be thought about, because our normal human reaction is to react to the crisis. So we got someone in front of us who's dying from an overdose. Of course, we want to help them, but you also got to think, no, wait a minute. If I've got millions of other people who could become that person 20 years from now, what do I do today so I'm not constantly running from crisis to crisis for the rest of the time?
So much interesting work to be done in the next decade. I was just thinking, like, so many fun threads to pull on there. I know that the preliminary data from the GLP-1 like drugs in regards to addictions to many different things are very, very positive and promising. I think we're still waiting for the phase 3s to read out, but I would be shocked if we weren't able to find meds that. The way I think about GLP-1s is there's nothing in our evolutionary history that prepared us for the abundance around us of things that are sweet and delicious and what have you. So, of course, almost everyone ends up obese without some way to modulate that, that primary pathway. And that's probably true for, like, all the things that we evolved to crave. There's nothing in our evolutionary history that prepared somebody for their first hit of an opioid. To your point about probably best to never try it, also relates to policies vis-a-vis people receiving pain meds, of course, inside the U.S. healthcare system, if they're not in a terminal disease state, is something else to discuss. But we are going to run out of time here. But Keith, I really want to thank you. This was really wonderful. I'll leave you with our final question we ask everybody who comes on the show, which is, the podcast is at the sort of the intersection of mental behavioral health, neuroscience, and in some cases the influence of AI on both of those. Curious about anything you're reading, listening to, watching that people who are interested in your work might find exciting. Of course, one that jumps out at me, for example, is for those who haven't seen, I think it's season 2 of The Wire, where they have the sort of the Amsterdam experiment, with a sort of quasi experiment off the books with this notion of legalizing drugs, and sort of the mixed results is one that I would think of when based on our conversation. But I'm curious if you have things that you're reading or watching or listening to that you'd recommend.
Yeah, what an interesting question. I mean, I am finding it fascinating to look at the incredible amount of public data that people post about their drug use and where they buy drugs and how they get drugs. And if there are now sites you can see, like, what drugs cost and where they're used, people are tweeting about these things. And some colleagues and I have been working on this team led by Russ Altman showing that you can even use that to predict overdoses. Like if you look at where people are tweeting the most about fentanyl, or where they're putting the most Instagram or TikToks about various drugs, you can predict the future. So that and that's really important, because most of the systems we have are kind of slow and clunky and all that. And the other thing is, it's a way to get honest information that is hard to get from a person. I mean, if you ask somebody, do you use fentanyl? They're very likely to say no if they do, but not tell you that much about it. But the anonymity of online, has people disclose a lot more. So it gives you if I'm outside the fentanyl using community, it gives me insight into what people say, what advice they give each other, what myths they spread, what truths they spread. And I find that all just, an incredible thing that comes out of these new technologies that we have. Of course, there's some problems that come from it, but this is something of letting us understand each other, which is, I think,
epidemiological leading indicator. That's amazing. Very interesting. We'll turn a hackathon loose on that and see if maybe some interesting tools for folks like yourself who are helping to make the addiction problem better can intervene. This is wonderful. Thanks so much for the time.
Thank you. Really great to be on the show. Be well.
Cheers. Thanks. The thing I keep coming back to from this conversation is Keith's point that social norms do more work than the law ever could. The reason drunk driving became unacceptable wasn't the arrests. It was the look on our friends' faces. If we want to fix addiction, loneliness, and the broader mental health crisis, we may need to think less about policy levers and more about the fabric of communities we're building. In the next episode, I'm sitting down with Dr. Deb Howry, former chief medical officer of the CDC, emergency physician, and one of the country's foremost experts on public health, injury prevention, and what it actually takes to protect people at scale. If Keith gave us the community view, Deb gives us the systems view. Neural Compass is brought to you by Jiminy Health. To find out more about Jiminy Health and how our clinical-grade AI solutions are helping to shape the future of behavioral health, visit JIMINIhealth.com. And then make sure to search for Neural Compass in Apple Podcasts, Spotify, or anywhere else your podcasts are found. Make sure to click subscribe so you don't miss any future episodes. And on behalf of the team here at Jiminy, thanks for listening.